In
Yes.
sake of time, we should probably start. Lung protective mechanical ventilation. I made an agenda. It's a huge topic. We could probably discuss 1 or 2 days about this. We will focus on a few particularly important things like limiting tidal volume, blood pressure, how to titrate PEEP, at least what we know about titrating PEEP, prone positioning, early neuromuscular blockage, and then extracorporeal life support and support mechanically ventilated patients. So, as in even outside of mechanical ventilation in medicine in general, the guiding principle is do no harm. And mechanical ventilation is a supportive therapy to help maintaining the gas exchange until the lungs recover from illness. And what we should try to avoid is additional injury from the mechanical ventilator-induced lung injury in barotrauma, volutrauma, arterial trauma, biotrauma, maybe myotrauma, that might actually aggravate inflammation and the underlying lung injury and therefore increase mortality. Here illustrated a paper from Claudia dos Santos where you and Dreyfus, where you basically see what happens to an animal lung. Here it's a mouse. If you are exposed to very high peak pressures during mechanical ventilation. And importantly, most of these strategies we've been talking about have been developed for patients with acute lung injury or ARDS. And as you know from the results of the LungSafe investigators, of the patients who had acute hypoxemic respiratory failure, only about 67 to 70% of these patients met ARDS criteria. So it's a very specific subgroup of the patient with respiratory failure, but we still use evidence from mainly ARSNet and NIH trials in order to extrapolate and protect all of our patients. And this is from the ARSNet investigators, the landmark paper, the most important paper probably in mechanical ventilation, where they compared traditional tidal volumes, 12 milliliters per kilogram predicted body weight. Predicted body weight is a function of height and sex, versus 6 milliliters per kilogram predicted body weight, although they were allowed to go up to 8 milliliters per kilogram predicted body weight if needed. And limiting plateau pressure in the control group, you see plateau pressures of 50 to less than 50. And in the intervention group of less than 30. And how do you accommodate for such a drop in tidal volume? You need to maintain the gas exchange, so you increase respiratory rate basically from 16 to 30 in order to maintain minute ventilation. You allow some permissive hypercarbia. You adjust your oxygenation target a tiny bit, and then you will be able to come down to 6 ml per kilogram predicted body weight. It always says low tidal volume ventilation, however, physiological tidal volumes are about 7 mils, so it's very high tidal volumes versus normal to lowish tidal volumes that was compared here in this trial. Dramatic difference in mortality, about 9%. Which is basically the trial stopped early. And is the landmark trial and the cornerstone of lung protective mechanical ventilation. Some things you might or might not know about that is with regards to limiting tidal volumes in observational studies, mainly the LungSafe study. This is a secondary analysis by Matt Nicholas and colleagues. Women and also patients with lower body height have a disadvantage in the sense of they receive higher tidal volumes per kilogram predicted body weight. And there was an association with mortality. However, in this situation, it's only day 1 data. I'm not 100% sure why it turns off. But if you look at longitudinal data, you'll see that women or female patients persistently over the entire duration of mechanical ventilation receive higher tidal volumes, and this is associated with higher mortality of female patients, even if you adjust for a potential direct effect of female sex on outcomes due to genetic differences or due to different baseline hazard of deaths, or height is a mediator of that. Importantly, also in the LongSafe study, but in our Toronto Intensive Care Observation Registry, in 30% of the patients we have not accurately or not measured height. And when we talk about limiting tidal volume ventilation, it's pivotal that you measure height in your patients. And ideally with a measuring tape, it's not sufficient to rely on your family member who tells you, oh, it's probably 182. You need to measure it with the measuring tape at the initiation of mechanical ventilation or at ICU admission, and then calculate daily the tidal volumes per kilogram predicted body weight and closely monitoring driving pressures in order to prevent these sex inhibiting tidal volumes. Now the question is, should we limit tidal volumes in all of our patients? Probably not. If you ventilate a relatively normal lung, a healthy lung with very low tidal volumes, you will actually cause injury, you will have derecruitment. But in patients, and this is an image of an ARDS patient with the classic bilateral infiltrates, and here you see the computer tomography, you see the baby lung, the lung that is functional and available for gas exchange. It becomes obvious that in this patient, if you only have baby lungs available for mechanical ventilation, that you need to adjust your tidal volumes, that you need to closely monitor your tidal volumes, and limiting tidal volume therefore, and this is a secondary analysis of the NIH ARDS trials by Jürgen Godiger and colleagues, limiting tidal volume, the effect is probably modified by respiratory elastance. And if you have a very high elastance, then you probably have a benefit in tidal volumes, while if you have an absolute normal elastance, there is probably more harm. We already talked about the equation of motion, so I will not talk much more about the equation of motion. And you talked about the difference in mechanical ventilation between normal breathing, like I'm breathing now, negative pressure with the diaphragm going down, and positive inspiratory pressure ventilation, where you basically push air into the lungs. And what we see, the numbers on the ventilator are the numbers measured at the level of the tracheal tube, but what causes the injury is somewhere in the alveoli, where you have rupture and inflammation, rupture of fibers and cells, and you have the chest wall and also the pleural pressure, which influences what the alveolar cells experience, the alveolar pressure. And you talked about the plateau pressure and the driving pressure. That can be calculated if you calculate the static driving pressure as peak plateau pressure minus positive end expiratory pressure. And from the LongSafe paper, we know that if driving pressure at baseline, day 1, first 24 hours, if it's above 14 centimeters of water, that these patients have a higher risk of dying. And the landmark paper with regards to driving pressure is probably the Marcelo Amato paper in New England Journal of Medicine, where you see that driving pressure at baseline and outcome, here a death in hospital, that there is a linear correlation. And this is basically almost a straight line. So there is no threshold of above or below 15, and if I measure the level is 15, now I'm safe. That doesn't exist, because 15, where you see that basically the regression line is crossing the 1.0 mark, that's just the mean driving pressure of the cohort. And you see the lower the better. It's still kind of unclear here. Many questions about this driving pressure analysis. It was in review for about 7 years. One thing is, when you already limit tidal volume, I mean, the pressure, if you set the volume, the pressure is kind of determined by the compliance of your lung. So is driving pressure or limiting driving pressure, is that a thing at all, or is it just a reflection of your respiratory system mechanics and reflects basically the compliance of your lung? And if you basically measure this at baseline, day one, and you show that it's associated with outcome at 60 or 90 days, there is a lot of mechanical ventilation in between. And so how do you know that we have to limit it, and how can you say it has a causal effect on outcome if you basically make an association between a baseline physiological characteristics and 60 or 30, 60 or 90-day mortality? So some questions. An additional problem there is we did not really include respiratory rate in the model. It was difficult to account for elastance in the models. So lots of debate about this paper. And on top of that, Gattinoni said driving pressure is only one variable. There is also other variables like PEEP or the tidal volume, respiratory rate, that should go into an equation, in this case the mechanical power equation, that basically explain how all these variables interplay and might cause lung injury. The formula of the derivation described in intensive care medicine is relatively complex. They provided a more simplified formula depending on your mode of ventilation, and the formula is not really used at the bedside because we do not have any randomized controlled trials or target trial evaluations that actually would tell us that sustained interventions based on mechanical power change patient outcomes. Nevertheless, it's a very important physiological concept, and it helps us to better understand how these variables may play together. Of course, Amato responded to this with another analysis published in the Blue Journal, where they reanalyzed all the NIH ARDS trials, and they basically, in reply to Gattinoni's mechanical power formula, said, you know, your mechanical power formula is predictive of your outcome, but you can simplify it and use a simplified 4 times the driving pressure plus respiratory rate, which is as accurate or even better predictive with regards to your outcome than your mechanical power. And they derived based on baseline measurements, that it's way more important to limit driving pressure than respiratory rate. However, still some questions kind of remain. ARMA trial, lowering of tidal volumes was basically, the result of that was that you had to increase respiratory rate from 16 to 30. So you seem to be able to double your respiratory rate and you will still have an improvement in outcomes. So whether we should limit respiratory rate, how much mechanical power that considers other factors actually play a role, or is it only tidal volumes and or driving pressure? We don't know for now. What was further puzzling is the results of the ARCH trial from Cavalcanti, where they basically investigated the long recruitment and titrated PEEP strategy, although with a very, very aggressive recruitment maneuver. So it's a joint intervention compared to a mechanical ventilation strategy with a low PEEP. And the result was that, that patients who received this lung recruitment PEEP titration had a significantly lower driving pressure, so driving pressure reduction was achieved, but still the patients in the intervention group had a higher mortality. And at the moment we don't know, we assume that it's this aggressive lung recruitment maneuver which led to the recommendations to abandon super aggressive recruitment maneuvers that caused the increase in mortality, but it's still kind of puzzling that despite these lower driving pressure values, that the mortality of patients was actually higher. With regards to driving pressure at baseline, although the LungSafe study from these 459 ICUs from 50 countries demonstrated that above 14 at baseline was associated with worse prognosis, only about 40% of patients had measurements for plateau pressure. And this is very similar to what we saw in the Toronto Intensive Care Observation Registry. Plateau pressure is not measured at the bedside often. And that's something, and you brought that up, how often should I measure it? Measure height, and the ventilator is a diagnostic tool. So when you initiate mechanical ventilation and when you do your rounds, you need to measure plateau pressure, you need to look at to understand whether the compliance or the resistance changed and monitor this. That's a diagnostic tool. And not only a machine that is somewhere in the corner. What about spontaneous breathing? At least in Toronto Intensive Care Observation Registry, after day 3, the majority, in day 2 and day 1, the majority of patients is already breathing spontaneously. How do we measure plateau and static driving pressure in these patients? It's feasible. Some ventilator will allow you to measure it. However, as demonstrated in Giacomo Bellani's anesthesiology papers, the measurement of plateau pressure was unreliable in about 10 to 20% of the measurements. And the reason for that, probably, Thomas, you mentioned that, is you wait for too long, you have a leak, and multiple other factors by static measurements for plateau pressure can not accurately actually reflect the transpulmonary pressures. Currently under investigation, occlusion pressures. We will hear a talk later about occlusion pressures, which might be a good surrogate for transpulmonary driving pressure and respiratory drive. However, consider that all of these values and even the static driving pressures during spontaneous mechanical ventilations have so far not been associated with outcomes, sustained interventions on those. Also for occlusion pressures, there is no data showing that titrating occlusion pressures actually changes patient outcomes. Although it makes physiologically, from a physiological perspective, absolute sense, and it's a value we measure routinely at the Toronto General Hospital, and we integrated like driving pressure, plateau pressure, tidal volumes into the daily considerations during rounds at the bedside, but it's not a value you target with religiously or very strictly. Using data from the Toronto Intensive Care Observation Registry, we tried to emulate a randomized controlled trial using observational data and compared basically usual care versus treatment strategies that limit static driving pressure to equal or below 15, equal or below 13, 11, and 9. And you see the lower your static driving pressure is, in the sense of the lower you are able to limit your static driving pressure, the better was mortality up to 30 days during mechanical ventilation. Interestingly, we found similar, if not more pronounced effects if you look at dynamic driving pressure. Dynamic driving pressure, which is P peak minus PEEP, also provides you similar information than static driving pressure, but as you mentioned, it measures alveolar pressures with noise. However, if you employ a treatment strategy where you reduced or limited dynamic driving pressure to equal or below 15 centimeters of water, sustained daily dynamic driving pressure, we found a nearly 2% reduction in mortality compared to usual care in all mechanically ventilated patients. And if you look at the dynamic driving pressure between groups, it's only an average difference of about 2 centimeters of water. Knowing the limitations of dynamic driving pressure in terms of reflecting alveolar pressures, it's continuously measured. You see it on minute by minute on your ventilator, and it provides you, despite the fact that it's measuring alveolar pressure with noise, some valuable information as well. How long do you need to limit driving pressure in your patients? Dynamic driving pressure is higher dynamic driving pressure is associated with worse outcomes during the entire duration of mechanical ventilation. At least we showed the association persists over the first 30 days of mechanical ventilation. And in this emulated trial using the Toronto Intensive Care Observational Registry, we also investigated different timings for the intervention. If you look here, intervention on limiting driving pressure only between day 1 to 5. You have some absolute risk reduction in mortality, minus 1.3%. But if you limit between day 1 and day 14, you have a higher risk reduction and it's more beneficial. Even if you miss the first 5 days of mechanical ventilation, there is still some modest reduction in mortality if you limit driving pressures. However, if you start limiting driving pressure at day 14 of mechanical ventilation, this effect becomes very small. So early intervention is very important.
So this is dynamic driving pressure?
Dynamic driving pressure.
Should you control for mode at all? Because I know if using volume control with high peak pressure will be higher than pressure control.
The modeling itself, the primary analysis was using the parametric G formula, which did not control for mode. But the secondary or sensitivity analysis used another model to model the exposure basically. And in this model, we are confident that mode has been accounted for as a residual confounder. Yeah.
But I think it is difficult controlling driving pressure if there is moderate to severe RDS because it changes according to delivering the tidal volume to the patient and maintaining oxygenation and ventilation.
It's a good question. How do you actually modify driving pressure? Ultimately, that's the question. There are limited options to modify driving pressure. You can change the tidal volume, you can titrate your PEEP, you can change your respiratory rate, and you can put your patient on ECMO and maybe sedation. So those are the 4 or 5 options. Which one is the right option? We don't know. This was an emulation of a pragmatic trial, so it was completely left to the physicians on how they want to modify driving pressure. Whether they titrate PEEP and try to modify it, or if they primarily use tidal volume reduction. But this is, we are currently running an RCT, a Bayesian platform adaptive RCT, to better understand how we should actually limit driving pressure. We don't know. Yeah. We talked about the PEEP titration. PEEP, you mentioned it during your talk briefly. It has advantages: improved alveolar recruitment, reduced lung stress, improves compliance, decreased area resistance, because you have less cyclic recruitment, you have less atelectrauma, reduced biotrauma, less inflammation. It also improves oxygenation, although you mentioned it, the PF ratio itself. Time-varying PF ratio is not necessarily an ideal marker to predict mortality. If you look at the ARMO trial, patients in the intervention group had way worse oxygenation than patients in the control group with the high tidal volumes, but patients with the worst PF ratios and the lower tidal volumes had the better survival. So PF ratio as a marker, we don't know. Improved oxygenation through modification of EQ mismatch and shunt fraction, also because it allows you to reduce FiO2. You probably have less oxygen toxicity, less free radicals, and therefore less inflammatory markers that are secreted and less inflammation, a possible reduction of extravascular lung water, and decreased work of breathing by basically matching to intrinsic PEEP. Potential issues, either due to lower tidal volumes or lower driving pressure, you might have impaired CO2 clearance, or due to alveolar overdistension, hopefully not, but it can happen. You can overinflate non-dependent alveoli, especially if you have very localized ARDS. It has cardiovascular effects, an increase in pulmonary vascular resistance, very relevant in patients with pulmonary hypertension. It changes your dead space, you have less blood flow in West Zone 1, can increase pulmonary shunt, and there are theoretical effects on the ICP, hepatic blood flow, and splanchnic blood flow. However, consider if you have a patient with brain injury, ultimately you still need to get oxygen to the brain. So, in the sense of you choose your PEEP, ideally the lowest possible to achieve sufficient oxygenation, and you need to be pragmatic there. Yeah, so in a meta-analysis of 6 RCTs comparing higher versus lower PEEP in these 2,580 patients, no significant difference in mortality. This is for ARDS patients, between a higher versus lower PEEP strategy. However, there was an individual patient meta-analysis by Briel and colleagues. They found that there might be mortality benefits in patients with moderate to severe ARDS, and that was defined by the PF ratio of less or equal than 200 millimeters of mercury, which led to the conditional recommendation in the guidelines that we should provide higher PEEP in patients with moderate to severe ARDS. Only 50% of all ARDS patients respond to higher airway pressures by decreasing the percentage of non-aerated lung tissues. We mentioned there are patients who respond, patients who do not respond, and it's currently an ongoing area of research. How do we actually identify people who might respond to PEEP? And there is, I want to only mention that to highlight that there is heterogeneity of treatment effects. The analysis of Caroline Calfee, who did the secondary analysis of ARTSNet trial, higher versus lower PEEP alveoli, and basically demonstrated that patients with the so-called hypoinflammatory subphenotype have a very different response in terms of 90-day mortality than patients with a hyperinflammatory subphenotype, and that inflammation and individual patient characteristics might actually substantially modify your response to PEEP. And remember, RCTs, we basically compare the average risk between two groups. So it's two big groups with very heterogeneous patients, and therefore no significant differences if you compare the entire Greek salad to another entire Greek salad. But individual patients might benefit a lot by titrating PEEP. How do you titrate PEEP? alveoli, I think, love and express used is lower versus higher PEEP tables, which is basically just an FiO2 PEEP scale, and you titrate it based on these scales. And that's also the recommendation in the current guidelines to use this. However, if you actually look at the lung-safe cohort study, and the same in the Toronto Intensive Care Observation Registry, severe AR, yes, average PEEP 10 now. So we are nowhere near the 20 or 22 of PEEP where we should be if we would follow these scales in real world practice. The best methods to set PEEP in patients with ARDS is unclear, but there, and in the sense of it's currently an area of active research, whether you titrate it to best static compliance, if you just use the scale, if you use EIP, you can titrate it to esophageal pressures, we will hear about that. You can use airway closing pressure, so recruitment to inflation ratios. You can titrate it to dead space. There are numerous ways to do it, and we still have to figure out how to do it. It's probably also balanced. If you consider the lung is, you will have different areas inside the lung, and you also have organs outside of the lung, hemodynamics. And you need to find the ideal balance for your patient where you do not have too much overdistension and not too much underinflation and also not too much hemodynamic compromise. And to find this sweet spot is part of medical art. Beyond the lung, I mentioned that there are effects of mechanical ventilation outside of the lung, and I want to illustrate this for cardiovascular effects. So positive pressure, mechanical ventilation, of course you have improved arterial oxygenation because you provide a higher FiO2. But you also have, due to the positive inspiratory pressure, less venous return, which basically from left heart perspective improves your Frank Starling by reducing the preload of your heart, a decrease in preload, but also a decrease in afterload. Remember, afterload is defined as the transmural pressure of the left heart, and if your heart wants to eject 100 millimeters of mercury here in these two situations, and you have negative intrapleural pressure, then your gradient across the wall, the left ventricular transmural pressure is 120 millimeters of mercury, while if you have positive inspiratory pressure ventilation, your left ventricular transmural pressure is 80 millimeters of mercury. And that's the reason why in very fragile cardiovascular patients, as soon as you extubate them, you have this change in ventricular afterload, and these patients go into pulmonary edema and are about to fail. And those are probably the patients who might benefit from non-invasive mechanical ventilation and further diuresis in order to be liberated from mechanical ventilation.
But experience post-extubation after relating with the hip venous been improved, and also the diuresis observation. I think it's, we will not experience this in pediatric age group above post-extubation pulmonary edema, even if the patient have cardiac issue before. If not have, it will be improved after relating with the pressure and increase venous and diuresis.
I have less experience about the pediatric population. The last time I did pediatric anesthesia is more than decades ago. So I'm very sorry for that.
I think in general,
But in general, yeah.
the idea is that your cardiac performance can improve when you remove positive vent expression, or PEEP and ventilation. However, in patients with insufficient cardiac, when they switch to now negative pressure ventilation, we may underestimate how this may overload the system and can put some, especially adult patients, into pulmonary edema. So it's a balance. Some patients may have decreased cardiovascular function that improves after extubation, and some it improves but not in a positive way. It now becomes overloaded.
Exactly.
So this is one of the reasons, this is a completely other subject, but this is also one of the reasons why some people may choose a different type of spontaneous breathing trial. So spontaneous breathing trials where we remove, like TPs, you will quickly identify patients who would go into this problem prior to taking the tube out. If you do a spontaneous breathing trial with pressure, you may not identify patients like this. So it's a balance, and there's a number of ways we can assess before we take the tube out if this is going to be, if it's going to be too much trouble for the patient. Versus, yes, you can have improvements that are not an issue, but in this population, it's a concern.
Yeah, you nicely closed the loop back to PEEP. That's exactly the reason why some people advocate for CEEP, so zero PEEP, in order to do a spontaneous breathing trial, versus a bit of PEEP. It's an ongoing debate. And importantly, you might see these arterial swing in patients that are very hypovolemic during ORs or in the ICU, and you will have these pulse pressure variations, but because of interventricular dependence, of course, if you have lots of PEEP and you have right heart failure, you have the septum bulging to the left side, impaired feeling of the left heart, and therefore also swings of the arterial curve. And PEEP, while it's good for the left heart, it might not necessarily be ideal for your right heart. And that's basically the left heart saying yoo-hoo, and the right heart is struggling because while you might have some recruitment and you improve the shunt and you improve oxygenation to a certain degree with PEEP, you might end up in a sweet spot, but if you then go further up with your PEEP, you will basically compress your vessels and you will influence pulmonary vascular resistance, and you will basically increase the afterload for your right heart, which might cause your patient to fail hemodynamically. Okay, next topic. Sorry, we have to go. It's a lot. We talked about higher versus lower tidal volume ventilation as the pivotal trial in lung-protective mechanical ventilation. I would say the second pivotal trial in mechanical ventilation is probably the ProSeva trial, prone positioning. Important things with regard to prone position is you need to prone for at least 12 or more hours. In the trial, they did that prone positioning for a mean duration of 17 hours. Mean or plus minus baseline PF ratio was about 100, plus minus 30 millimeters of mercury. We currently do not know what is the ideal marker that is a good surrogate for mortality and tells us whether the patient's response to prone position whether it's actually working or not, and also when we have to stop it or not. PF ratio might not be the ideal marker, that we know for sure. Maybe it's ventilatory ratio, maybe it's death space, maybe it's change in respiratory mechanics that will tell us whether a patient is a responder to prone positioning. The bottom line is in the trial, in the protocol, they proned up to, I think it's 3 or 4 weeks, theoretically, just flipping back and forth. And the average number of prone sessions was, I think, about, was it 4? 4, yeah. But the bottom line is for patients meeting the PF ratio threshold, prone position is, together with limiting tidal volumes and plateau pressures, our most successful strategy to improve the survival of patients with ARDS. Mechanism, decreased gravitational pressure of heart and mediastinum on the lungs, also decreased compressive effects of the liver through the diaphragm, and because you have a restriction of anterior chest wall movement, you have a more homogeneous chest wall compliance. Those are some of the reasons I proposition my work. Then what we also have on this famous graph in the Berlin definition paper, early neuromuscular blockade. And initially we thought, okay, we have to paralyze our patients based on the Accuracy trial published in New England Journal of Medicine, done by Papazian, where they, in ARDS patients with a PF ratio of less than 150, started with 50 milligram bolus of cisaldecaolin, and then an infusion, a fixed rate of 37.5 milligrams per hour for 48 hours. So it's not titrated to train of 4 or milligram per kilogram per mix, 37.5 milligrams per hour, fixed rate, a high dose, and they found a dramatic difference in mortality, although the trial was stopped early because of that, and maybe the sample size includes the possibility that there was no difference at all between the two groups as a limitation, but that's basically the group mortality difference, and there was a high recommendation to paralyze for the first 48 hours all ARDS patients. Then they tried in the ROSE trial to replicate in North America the results from the groups in France, and the management was slightly different. There was the use of higher PEEP in the group in these patients, lighter sedation strategies. Here patients were deeply sedated, and here lighter sedation targets, and you see there was no separation between intervention and control group, suggesting that neuromuscular blockage might actually not work. However, there are other important differences between the two trials here. About up to 50 to 70% of patients I think received proposition, while only 16% of patients were prone in this trial. And also these patients were recruited in the emergency department, and between screening and actually inclusion into the trial, many had already received neuromuscular blockage, and many improved. So they were probably not the true ARDS patients. They had hypoxemic respiratory failure, but within 48 hours it basically already resolved. So maybe multiple effects. First, differences in sedation strategies, in prone position, and in how they titrate PEEP, but also differences in the patient population that was selected for these two trials, which might explain why we found no effect in the ROSE trial, and we found a striking effect in the Accuracy trial, and the bottom line is we have no idea whether we should paralyze or not. Oxygen therapy. There is an entire battery or a large number of trials. Hot ICU trial is a famous one, or the ICU ROX trial. The ICU ROX trial is probably the most recent and the largest one, with 965 mechanically ventilated patients, where they compared a saturation target between 91 to 96% versus usual care, and no difference. However, in subgroup analyses, there might be mortality differences for hypoxemic ischemic encephalopathy, sepsis, and acute brain pathology. And because, I'm not sure why it always turns off, I did not stand on the cable. And because we had these signals in the subgroup analyses, the group from Wisconsin did an analysis also to see whether there is heterogeneity of treatment effects. And they basically use machine learning methods to see if different candidate predictor variables kind of modify the individual treatment effect for patients. Importantly, you cannot measure individual treatment effects except for crossover trials. It's all hypothetical, but still they found that there is significant heterogeneity of treatment effects, and that depending on whether, based on your markers, you favor a lower SpO2 target or a higher SpO2 target, that you might have up to 30% difference in mortality risk, depending compared to the average effect, depending on these effect modifiers, suggesting that what we see here in this large trial is also just an average difference between groups that does not really tell us how the individual patients might or might not respond to titration of oxygen. From the analysis of Maturpec, we see that older male patients with brain injury or cardiovascular disease benefit from lower SpO2 target, which is kind of in line with other trial data where we know that hyperoxemia, especially in brain injury or cardiovascular collapse, is potentially detrimental, and that younger patients with sepsis and respiratory disease benefit from higher SpO2 targets. And I show you here the rank plot where you see the predicted individualized treatment effect for each patient, and you see compared to the average treatment effect is a 30% predicted individualized treatment effect in both directions depending on your biomarkers, age, and respiratory rate, temperature, heart rate, and mean arterial blood pressure. Extracorporeal carbon dioxide removal. The REST trial, you all read the REST trial probably in JAMA, where they basically investigated whether extracorporeal carbon dioxide removal, ECOR, is a strategy to provide ultra-long protective mechanical ventilation, titrating high volumes to ECOR less than 3 milliliters per kilogram for at least 48 hours versus conventional mechanical ventilation. And the results in terms of all-cause mortality at 90 days, 41 versus 39.5%, a non-significant 2% difference in mortality risk, which basically led to the conclusion that we should not provide ECOR to limit high volumes or provide ultra-protective mechanical ventilation outside of research studies. So it's not the time for prime time, or it's not prime time for ECOR. However, the trial also has some flaws. First of all, a low rate of composition, only 11%. Many centers were inexperienced with ECOR that were included into the trial, and it's important to know that this trial investigated the complex joint intervention. It's not just ECOR, it's an entire bundle of care that was investigated. And probably the most important thing is there are big questions about generalizability. If you look here at the patient flow, 7,071 patients were screened, but only 6% of those screened patients were actually included in the actual study, which is not a selection bias, it's selection of patients, but it's a threat to external validity of the study because potentially a lack of generalizability. Who are actually these patients that fit these criteria, and does it work for all patients outside this very, very limited patient population? Very different for extracorporeal membrane oxygenation, so where you use ECMO to basically disentangle gas exchange from mechanical ventilation, with a focus on oxygenation. These are the results from the EOLIA trial, where you see that there is about an 11% reduction in the risk of death by ECMO versus control group. The frequentist analysis was statistically non-significant, but Golliger and colleagues in JAMA published a Bayesian reanalysis, and demonstrated that the posterior probability of mortality benefit, meaning a relative risk of less than 1, is between 88 and 99%, basically suggesting that ECMO is highly, highly effective in these patients. And the bottom line, or what I want to show in this slide, is if you reach the limits of conventional mechanical ventilation, if you see that you're not able to control your plateau pressures, if you are at the very limit with your gas exchange, if you tried prone position, you tried trial of neuromuscular blockade, call your ECMO referral center earlier, ideally earlier rather than later, because like mechanical ventilation, ECMO is a supportive device that allows you to basically reduce the risk of experiencing ventilator-induced lung injury. So if you already ventilate for 12 days with really high pressures, you destroy all the lung and you also destroy the potential benefit that is provided by extracorporeal membrane oxygenation. Finally, mechanical ventilation, it's not only about the numbers that you read on the monitor. It comes with a large amount of supportive care that is also important for the outcome of your mechanically ventilated patients. Do daily sedation interruptions, assess if the patient can be liberated, routinely assess pain. In Margaret Herrich's work, you basically see that many of the patients, when they are in this kind of world in between there and in a dream and some delirium, suctioning feels like torture. It's really painful. And it's an obnoxious stimulus that occurs over and over again, and you wake up, you hear the noise of the ICU environment. So it's very important because that will cause post-traumatic stress disorder, and patients, when they come off the breathing machine and can go home, they will suffer from this for years. You should also reduce bed rest to a minimum. There is no good reason, if you can avoid bed rest. For the majority of conditions, there is at least a possibility to wean sedation and to start doing some physiotherapy. The most recent results of the TEAMS trial, they investigated a very aggressive strategy of mobilization versus normal mobilization. It does not mean that you should keep your patients asleep in bed. And actually, another advantage of extracorporeal membrane oxygenation is that you can let your patient wake up, you can have them participate and communicate, guide the decision making, and let them walk around.
I'm just wondering regarding the last two papers that we have posted regarding ECMO and the conventional ventilation, which I'm not sure, but I haven't read all the studies. But I'm thinking, is sedation a part of the success of the second trial? I mean, not using sedation or minimal sedation, while the other conventional was supportive with the use of minimal sedation. And the other thing regarding team trials, which I have a lot of issues with that trial, that they keep the patient sedated and they wake them up to do the therapy and then they return the patient to be sedated.
Exactly.
Which, in fact, you're not giving a true rehabilitation in the ICU.
There are many limitations there. I agree with you. Because of time limitations, I could not take into the details of the TEAMS trials. I just wanted to mention the TEAMS trials should not prevent you from waking your patient up and mobilize them. It's really important to do that. Ideally, the patient, and I know with COVID, everybody is now on triple and sedation, and we kind of made all the steps back to an era that we thought has passed. But ideally a patient is not sedated at all and just has a bit of pain medications, PRM. It's totally feasible to do mechanical ventilation like that. And if the patient is so critically ill, then consider ECMO and let the patient wake up. It's currently an ongoing area of research whether we should use this PF ratio of less than 80 threshold to initiate ECMO, or if there is a group of patients with a PF ratio, let's say less than 120, there is some data, and put these patients on ECMO, let them wake up and avoid detrimental side effects of bed rest, sedation, and ventilator-induced lung injury. So yeah, that's an area of research. And finally, avoid physical restraints. I know if we have awake patients, we are kind of anxious that they extubate themselves. However, keep in mind, these patients, they have septic encephalopathy, they are in delirium. You basically, being completely sedated, you wake up, you try to rescue yourself out of these situations, and you are tied to the bed. It's brutal. That also is associated with PTSD and will determine the other patient important outcomes than mortality, which should be also in your focus. It's not all about mortality in terms of mechanical ventilation and ICU care. The bottom line: prevent overdistension, prevent underinflation, allow permissive hypercapnia, if necessary, accept the lower target SpO2 of above equal or above 88%. Open the lungs when possible, so PF ratio less than 200 is conditional recommendation for higher PEEP. However, avoid aggressive recruitment after the R trial. Don't do that. Recruitment is still recommended, but for sure, no staircase maneuvers and super aggressive recruitment anymore. Avoid oxygen toxicity, so that's why we on ECMO dropped the FiO2 on the ventilator to 50%. It's arbitrary, it's expert opinion, but we try to reduce these reactive oxygen species. Do your daily SBTs and sedation stop. Remember that prone position and ECMO therapy together with low tidal volume ventilation are probably some of the most successful strategies in order to treat acute lung injury and respiratory failure.
All very So use a different background. So for this next topic, I owe some thanking to Alberto Goffi, who's another speaker. We prepared this module together. So we're talking about use of esophageal pressure, esophageal manometry in patients mechanically ventilated. So what it means, okay, and how to do it, and when to do it. So these are all the papers that you need to read, study, and memorize. Okay. So few concepts. So this is a scheme of lung in the chest wall. As Tom said, the chest wall is the rib cage and the diaphragm. Pleural pressure, alveolar pressure, and some definitions. So the pressure of the respiratory system is airway pressure minus atmospheric pressure. We always assume atmospheric pressure is 0. So the airway pressure that you measure by doing plateau pressure is really your alveolar pressure. Okay, so you're measuring alveolar pressure. So transpulmonary pressure, which for this presentation we indicate with PL, L as lung, the distending pressure of the alveolar unit, is airway pressure minus pleural pressure. Okay, that's the transpulmonary pressure that it's gonna distend and inflate the alveolar unit, okay? And then the pressure that is distending the chest wall, okay, is pleural pressure minus atmospheric pressure, and again, atmospheric pressure is assumed 0, so your pleural pressure is surrogate or is equal to your chest wall pressure, okay? All right, so remember the transpulmonary pressure, okay, is alveolar pressure, so airway plateau pressure if you want, minus pleural pressure. So how's the pleural pressure distributed in a normal subject or in a patient? Is equal everywhere around the lung?
No.
No? Okay. So that makes things very difficult, right? Because, so where is, let's say, in a patient that is spontaneously breathing, or in us now, spontaneously breathing, the pleural pressure is positive or negative? Negative. Is more negative at the apex or at the bases? At the bases. So our transpulmonary pressure is different, okay? Going from the apex to the base of the lung. Okay. In a patient that is sedated and paralyzed, okay, the pleural pressure is positive or negative? Positive, okay? And where is more positive? In the non-dependent area or in the dependent area? The dependent, right? Because there is all the weight of the body and the lungs, okay? So it's very positive. So again, it's very different, the pleural pressure, okay? So the transpulmonary pressure, understand the transpulmonary pressure, so the pressure that distends the alveolar unit, is very dishomogeneous distributed, okay? So, and we don't control it, right? Because we measure, usually, as we said in all these presentations today, okay, we measure airway pressure, okay? Plateau pressure or peak pressure, okay? We measure surrogate of distending pressure, okay? We use plateau pressure as a surrogate. We know and we need to maintain it below 30 or usually below 30, okay? But we don't know what is the resultant transpulmonary pressure, so alveolar distending pressure, okay? Which can be very high, okay, if the pleural pressure is low, or very low if the pleural pressure is very low, okay? And that's what this figure wants to show. If the component of the chest wall, okay, is very small, okay, the airway pressure, okay, is gonna affect very much your distending pressure, the distending pressure of the alveoli. Instead, if you have a very huge component of the chest wall, okay, the distending pressure, so the pleural pressure is very high, the distending pressure of the alveolar unit is small, okay? This is very well explained by elastance. So the elastance of the respiratory system, Tom, you explained the equation of motion, and Martin explained elastance is the change in pressure divided by the change in volume, okay? And we know that the elastance of the respiratory system, and the respiratory system includes the lung and the chest wall, okay? So the elastance of the respiratory system is equal to the sum of elastance of the lung plus elastance of the chest wall. So you can imagine, if the elastance of the chest wall is very high, for the same elastance of the respiratory system, so the same pressure, we maintain the same pressure, the same volume, okay? But if the chest wall elastance increases, the elastance of the lung decreases, okay? And vice versa. It's all clear? Okay? So based on these reasoning, physiologic reasoning, okay, we said that many investigators start wondering, how can we measure, okay, the elastance of the chest wall, okay, so that we can titrate the pressure based, targeting or based on the distending pressure of the lung, so the transpulmonary pressure rather than plateau pressure, because plateau pressure may not be inadequate, okay, surrogate for distending pressure of the alveolar units, which is the main effector of ventilator-induced lung Okay? Good. So we measure esophageal pressure, we'll see how, okay? And we measure esophageal pressure. Why we measure esophageal pressure? Because we want pleural pressure. So why we measure esophageal pressure? Because we should measure pleural pressure. We said that the transformer pressure is airway pressure minus pleural pressure. And now all of a sudden we measure esophageal pressure. Why?
Because it is intrathoracic components are affected by positive pressure in the thoracic.
Yeah, so it's the closest surrogate. So esophageal pressure, okay, is the closest surrogate for pleural pressure. I'll show you some images in a second. Okay, because the esophagus is contained, okay, between the two pleura, the two chest pleura. Okay, and so if we measure in a certain way esophageal manometry, we actually measuring pleural pressure. Now, where do we measure pleural pressure? We measure pleural pressure in that specific spot. Okay, and remember the pleural pressure changing all over the respiratory system. Okay, so there is a huge assumption that one value that we measure in a specific anatomical area, okay, is representative of the all pleural pressure of the patient. Okay, it's a big, big assumption. Okay, okay, good. So there are two approaches to these, two physiological approaches to these measurements. Okay, to consider pleural pressure as a perfect surrogate esophageal pressure as a perfect surrogate of pleural pressure. Okay, so we consider the absolute value of esophageal pressure as pleural pressure. Okay, this approach that is being used by Daniel Talmor in Boston. Okay, he published EpiVen 1 and EpiVen 2. We'll look at the data. Okay, and then there is the best, the second method. Okay, developed by Gattinoni, Ranieri, Pesenti, so the Italian crew here. Okay, the elastance derived method. Okay, so we'll go through them. It's easy. So the easiest is absolute value. Okay, we measure esophageal pressure. Okay, we'll check out to measure it. It's relatively easy, and that's equal to pleural pressure. So it's very easy. We are patient. Usually we can do it in any kind of modality. Let's say the patient is sedated and paralyzed. We put the esophageal catheter. We do all the maneuvers when we know it's in the right place. We check how to do that. We do an expiratory pause. Okay, so we know total PEEP, and we measure the esophageal pressure during the expiratory pause. So we have total PEEP minus esophageal pressure, and we get R and the expiratory transpulmonary pressure. So and the expiration, we know if the airway pressure, okay, which is alveolar pressure, is higher or lower than the esophageal pressure. Okay? We can do that at end inspiration, so we measure plateau pressure minus the plateau of the esophageal pressure corresponding. Okay, and we do. So it's very easy because I think even my daughter that is in elementary school can do one minus the other. Okay, so very, very easy. It's a bit more complicated, the elastance derived. Okay, but it's not so complicated because remember, we said elastance of the respiratory system is equal elastance of the lung plus elastance of the chest wall, right? Okay, so if we measure elastance of the chest wall and we measure elastance of the respiratory system, we get to know elastance by subtracting elastance of the lung. Okay, good. So to measure elastance of the chest wall, we do esophageal pressure at the end inspiration minus esophageal pressure and expiration, doing the two maneuvers, and divided total. The respiratory system is plateau pressure minus PEEP divided total volume, and so we can get elastance of the lung. Okay, and the elastance of the lung is divided, multiplied by total volume, give us the transpulmonary pressure. Okay? If we do this in a simplified way, okay, we can do transformer pressure is plateau pressure, okay, minus driving transformer pressure divided plateau pressure, okay? Or if you want, elastance of the lung, okay, divided elastance of the respiratory system. And elastance of the lung is elastance of the respiratory system minus elastance of the chest wall, okay? Okay, it's done,
So we get the last number after we measure the esophageal pressure.
absolutely. To do
My online
PL,
calculator does all of this for you.
yeah, to do PL, you need to have the elastance of the chest wall, okay?
But really simplified is the last part of that equation is a fraction. You're saying, with my airway pressure, what fraction of it is felt by the lung? So you're multiplying the plateau pressure you see in the ventilator by the elastance ratio. The lung elastance divided by respiratory system, it's just a percentage of how much pressure is reaching the lung.
Yeah.
So when your plateau is 30, you're like, how much is reaching the lung? You multiply it by that ratio. It's 80%, 20%.
Exactly.
It's a nice picture.
So let's say that the elastance of the chest wall, okay, is
This is a great
okay, good. So percentage, okay, here, elastance of the chest wall is 20% of the total elastance, okay? Here is 50%, okay? So here is half, here is 20%. So if your plateau pressure is 30, okay, your transformer pressure, okay, is 80% of 30, right? Because 20% of the pressure is dissipated, is used to to distend the chest wall. So 80% is used to distend the alveolar unit. So you're actually distending pressure of the alveolar unit is 24. Okay? Here is 50%. Okay? So if the plateau pressure is 30, the transformer pressure, so the distending pressure of the alveolar unit is 15. Okay? It's good. Okay?
You would have a very difficult time ventilating that patient, especially if you try to work within the limits of ARTSNet. Right, so this is that patient, obese patient, abdominal compartment syndrome, the chest wall is so stiff that even if you went up to 40, it's 50%, they're still only distending along by 20 centimeters. Right? So,
And also related in that paper also shift over the system. I think this may be rigidity and affecting the elasticity.
Yeah, so the patient with pancystitis, for example, abdominal compartment syndrome, obese patient with volume, fluid overload, okay, they all affect the chest wall. Okay, so your distending pressure of the respiratory system is very much affected. Okay, so keep in mind that all these we'll look at some clinical evidence. All these is very fascinating from a physiologic perspective. Okay, the translation in clinical practice at the moment is very good. Okay, using all these to save or to improve outcome. Okay. Okay. So which one should we use? Should we use the directly measured? Because the directly measured, as I said, okay, so look at these graphs. Okay, this is a paper by Yoshida and Rochard, the Blue Journal. Okay, they did a very nice study. Okay, they took pigs. Okay, they put pressure transducer in the chest. Okay, in the chest wall, in the lung of a pig. Okay, so and then they put the esophageal balloon. You understand the esophageal balloon? You see the esophagus there? Okay, see the two bronchi? Okay, and then just above the aorta there is the esophagus with the catheter. Okay, and the balloon. So we measure the pressure in this point. Okay, and we want that to represent the entire pleural pressure. Okay, which is very different here from here. Okay. Very different, and we measure it in one point, and that's our surrogate for the whole pleural pressure. If we use the direct measure, so should we use that? It's a big assumption, okay? Because as you said, clearly said, the pleural pressure is very high, and here it's very low. okay? And if you use this point here, okay, it's only one number, okay? So it's big assumption, okay? Okay, where's the, okay, so what they did, they check, okay? And you see here the non-dependent sensor, so this line here is the pressure, okay, of the non-dependent areas around here, okay? And this one is the pressure of the dependent air, okay? And you see here, especially these are different peak, okay? So we increase the peak, okay, from 4 to 22, 24, okay? And the esophageal pressure, okay, was very close to the pressure of the dependent air, this part of the lung, okay? And far from the non-dependent air at different levels, okay? Good. So if the purpose of measuring esophageal pressure is to maintain recruitment and end expiration, okay, it's okay. Okay, maybe this is a good surrogate. Okay, whereas if you want to prevent overdistension, okay, this is not a good surrogate because we're very far from the pressure, okay, of the non-dependent. Okay, they did that. They used cadavers in Quebec. There is a place where people can donate their body for research after death. Okay, they did the same thing. And here was halfway, because anatomically, the distance between the dependent areas and the esophagus is larger in humans than in pigs. Okay, so it was halfway. Big assumption. They did the same thing for, and used they did the calculation with the elastance-derived method, and they found that the elastance-derived method actually provides numbers that are very similar to the non-dependent area. So we could use those, okay, for strategy to avoid overdistension rather than avoiding the recruitment. Okay? Okay? So how to do it? So we need this esophageal balloon. There are different kinds, okay? Is a catheter, okay, with the balloon at the bottom, usually latex, okay? There are many different, okay? Each balloon contains different amount of air, which is important. We put this balloon in the esophagus just like an NG catheter. Put it down. There are different ways to do it. Some put it down to 60 centimeters, and then they do them in order to check the right position coming back, okay? Or you can do the opposite. Going forward, it's easier to come back, okay? There are some assumptions. So then we inflate the balloon, okay, with some air, okay? So usually what we want, because we want to measure, remember, we want to measure the pressure of the pleural space, okay? And the esophagus is contained in the pleural space, okay? So we need to have our balloon, okay, with the walls tight in contact with the esophageal wall, okay? So the esophageal walls is just a membrane, okay, separating our balloon from the pleural space. That's how it's a good surrogate. So now, if you overinflate the balloon, okay, the pressure is overly increased, okay, overpressure. So you measure the pressure of the balloon rather than the pleural pressure. So you want the balloon to be in touch with the esophageal wall, but not to be overinflated, okay? And so how do we do it? We overinflate the balloon, so we are sure it's attached to the wall, and then we start deflating it. So if we want, for example, to put 1 ml of air in that particular esophageal catheter, we put 2 ml and suck 1 back. Okay, so we are sure the balloon is in touch with the esophageal wall. Okay, because if there is air, that's going to dump your transmission of pleural pressure. Okay, so there are many assumptions. The pressure measured in the esophageal balloon accurately represents the pressure in the esophagus. The transmural pressure of the esophagus is 0. There is no compression of the esophagus by the heart or other structures. The pressure in the mediastinum surrounding the esophagus is equal to pleural pressure. Okay? So we need to believe all of these, okay, to make sure that especially if we use the directly measured values, okay, these are all the assumptions. If we use the elastance derived, because remember, with the elastance derived, we calculate the chest wall elastance. So esophageal pressure at end inspiration minus esophageal pressure and expiration. So all these assumptions are gone because they are one minus the other, so they eliminate each other. Okay? So the assumption is physiologically is more sound. Okay? Okay? The Italian way. Okay? But that's one of the potential issue. Okay, so now how do we know, okay, is in good position? So we need to do the occlusion test and what we call the Bider maneuver, okay? So ventilation, we occlude, okay, usually end expiration. There's no flow, okay? And we press on the chest of the patient, okay? Press on the chest of the patient. If the balloon is in the esophagus, we should see positive pressure, right? Because we press on the balloon. But we press also on the lung. And the system is closed, so every pressure should be equal. Every change in pressure should be the same. So your transpulmonary pressure should be 0. Okay? So the same change in airway pressure, okay, is measured in the esophageal string as well. Okay, so if you find that, you are in the, so there is perfect correlation between airway pressure and esophageal pressure, you are in the right spot. If the patient is breathing spontaneously, okay, you don't need to press the chest. You do the end expiratory occlusion, the patient takes a breath, so your esophageal airway pressure drops, okay, the P-op, is going to talk about, and your esophageal pressure also changes, and the change should be the same, okay, with the pleural pressure equal to 0. So again, you know the balloon is in the right spot. This is a must. You need to check these before using any values that you're reading, okay? The tolerance is plus minus 10%, okay? So you do this maneuver, your change is plus minus 10%, you're good. Then you can decide if you want to use it with the absolute values or elastance derived. The air that you put in the balloon, depending on the balloon, is very important, okay? Here, for example, they show that as you hyperinflate the balloon, your esophageal pressure measurement increases dramatically because one of the assumptions that we said, the 4 assumptions, is gone, okay? So be careful and try. Usually the first time for a particular patient, we try a few, 1 ml, few volumes in the esophageal balloon to make sure that we are reading exactly, okay, what we want, especially if you make clinical decision, okay, for that patient. So we can use it in different ways, okay? We can partition the respiratory system, chest wall versus lung. We can use it for PEEP titration to calculate stress and strain, workup breathing, detection of intrinsic PEEP, asynchrony. Okay, transdiaphragmatic pressure. Okay, first paper, okay, is by Talmor and Pivet 1. Okay, they titrate transpulmonary pressure and expiration based on absolute value, okay, to be 0 or positive, okay, 0 plus 1. So airway pressure, esophageal pressure, this is the transpulmonary pressure and expiration. You understand the end expiration is all negative, okay? So the lungs in theory tends to collapse, okay, at the bottom. And we saw good evidence to show this. So they would titrate the PEEP up, okay, airway pressure up, so that the transpulmonary pressure and end expiration is positive, okay? And they show They use tables to help with the titration. They show that the PEEP was significantly higher, and there was a trend in better oxygenation and better survival, or not, although not powerful survival. There were lots of surgical patients, so maybe very recruitable with very much atelectasis. Okay. Unfortunately, the EpiVent 2, which was a larger multi-center randomized trial to confirm the effect of this strategy, didn't show any difference. Sorry, I didn't report here, but didn't show any difference. And they use a high, as a control, the high PEEP FiO2 table. And the main result was that the people were equal across groups, except maybe for the very severe category of patient, okay, where there's higher PEEP in the esophageal guided PEEP strategy compared to the others. Maybe an effect there. But that paper really killed the enthusiasts to use esophageal manometry to titrate PEEP, okay? Another paper that we published during the H1N1 outbreak in 2007, 2010, between 2009 2010. Okay, so we were receiving patient, we were ECMO center in Italy and receiving patient for ECMO consideration. So we were titrating PEEP based on elastance-derived method, okay, and changing PEEP, okay, to target transpulmonary pressure based on elastance-derived of 25, okay, and there were patients that were avoided, okay, that were very recruitable, okay. We avoided to use ECMO in those patients, okay, because the chest wall elastance was impacting the distension of the recruitability of the lung, okay. It's an observational trial, few patients. Nobody in Italy wanted to do a true large multi-center randomized trial, so it's left, you know, for exactly this opportunity to trigger some physiological thinking more than changing clinical practice. Okay, in difficult weaning. So there are other ways to use why esophageal manometry may be useful in the medicine. Okay, patient is difficult to wean, and we can really measure inspiratory effort. Okay, so for example here, failure group, you understand the beginning, you see the swing of esophageal pressure, that is a surrogate for work of breathing, okay, or respiratory distress, and the failure is much increased compared to the success group beginning at the end, which is very similar. Okay, the work of breathing didn't change. And you can use this very much. You can understand if the patient has an effective breath triggering. Okay, this patient usually with COPD and higher intrinsic PEEP, they cannot trigger the ventilator. So we increase the PEEP to match intrinsic PEEP and the ineffective breath outcome. Okay, maybe Tom will talk more about this. Okay, different kind of asynchrony, double triggering, reverse triggering. I leave to Tom to talk, but these are all hidden phenomena. If you look only at the pressure and the flow curve on the ventilator. Okay, if you have an esophageal manometry checking the activity of the diaphragm, okay, by measuring and monitoring esophageal swing, many more data, okay, will appear. What to do with this data is still a bit unclear. That's why all these is to be taken with some grain of salt. Okay, it's good to understand better what's happening to our patient. Okay. Esophageal manometry may help us in understanding that during spontaneous breathing we are actually inducing lots of ventilator-induced lung injury. This is a nice case report by the group of Antonio Presenti in Milan. Okay, they had a patient on ECMO, ventilated with volume control, it's a people 15, total volume was 4 ml per kilo predicted body weight, peak pressure was 37, and esophageal pressure, the swing was +2, okay, with transformatory pressure of 12, calculated, okay. Now they changed to pressure support, the patient started generating spontaneous effort, inspiratory effort. Beat is the same, the total volume increased to 6.5, the peak pressure is 24, okay, this pressure support is actually much better, okay. The pH even better, but what they put is esophageal catheter, the swing was -35, so then if you do the calculation, transformer pressure is 38, okay, extreme, the transformer pressure 38 centimeters, huge alveolar inflation there, so extremely high risk of ventilator-induced lung injury, okay, which if you don't have esophageal pressure is completely hidden, okay? And that's why when Dr. Alvarez, the chair of this conference, was in Toronto, I asked him to measure esophageal pressure in all ECMO patients for 1 year, every day of the ECMO run, okay? And we'll present the data during the conference. But it's a big, so you can use it to measure PL and NC by changing in the ECMO, the sweep gas flow, so changing the extracorporeal CO2 removal to control the work of breathing and the distending pressure of the lung. Another paper that we did with Abdulrahman, okay, during that trial, is to look at the total volume, heart rate, and esophageal swing in patients undergoing a sweep-off trial to see if we should decannulate them or not. Okay, we took all the patients that were decannulated, okay, but some of them, about 30% of them, needed to either be recannulated or have their vent settings increased or being treated with vasopressors that were doing poorly, so meaning that decannulation was unsafe. And we studied those patients. We found that the unsafe decannulation, liberation from ECMO was associated with increased total volume during the sweep-off trial, increased heart rate, but also increased esophageal swing as a surrogate of work of breathing. Okay, so there is a value that may be, this is also single center, few patients, okay, but there may be a value in measuring esophageal pressure more to measure and monitor work of breathing rather than setting a ventilator parameter. Any question?
We have these esophageal monitoring. Could that tell us when to leave ECMO? We have the data.
That could be, it's not being done, but that could be potentially done if you measure work of breathing. Yeah, we didn't find, no, we found, yeah. So in the paper I mentioned, that will present the result. Okay, there is an association, okay, of dynamic driving pressure over time, daily measure of dynamic driving pressure and the outcome, but also the esophageal pressure, esophageal swing. So if it's too small, it's very bad. This means that the patient is too sedated or is too sedated maybe because it's too sick. But also if the esophageal swing is too high, okay, that's associated with bad outcome. Okay, so that would be important.
As a direct consequence, you can see the data.
Yes.
It's interesting.
Okay, so yeah, maybe again it's a single center because same data as the data from the same patients we use here. So there are some limitation, but the signal is good.
How many centers do you have? What's that? 4. 5, yes.
So I think we're obviously very behind in time. Some of the talks are probably gonna be a little bit shorter. They're everybody hungry? Do you want to stop for lunch, or do you want to go through one more? What do you want to do? We'll make a vote. Who wants to stop for lunch now? Who wants to keep going with it?
Okay, we can completely tailor it to your.
Yeah, this is, like I said, it's very informal. So if you want, maybe
Measure
we'll.
your esophageal.
Yeah. So maybe we can do one where I can do electrical impedance tomography, and then we'll reassess whether or not we want to do one more or have lunch. Is that okay? Okay, all right. And I will try to make this one shorter than my slides. Okay. So how many people are familiar with electrical impedance tomography? Show of hands. You've heard about it. Has anyone used it clinically? Oh, you have? Excellent. Okay, so I'll let you do the talk. All right, so this is a device called electrical impedance tomography. I have many slides, but I'm going to probably just describe it with this belt here. So it's a device, it looks like a ventilator because if you notice the screen is almost identical. They actually use, this is a larger Draeger screen, but their ventilators use very similar screens. This device here has a huge, what's called the trunk cable. This cable has a right and left. You can hold this up, you can see right and left here. And we place this belt, this is obviously a pediatric belt. This is an adult belt, I'm going to show you both because this is a medium adult belt. Notice it's just rubber, it's reusable, it can be cleaned in between uses. Other devices on the market are stickers, so when you apply it to the patient, when you're done, you throw it in the garbage. This one you can wipe and use with other patients. You'll notice these black marks, they're leads. There are 16 leads on this belt. The other manufacturer has 32. They'll argue that 32 is better, some say 16. This is sufficient, I assure you. It depends on how accurate you want your pixel perfect data, but anyways. This here, it goes around the chest. It just snaps like that. When the trunk cable is connected to it, I'll show this one now because it has it connected. I'm just going to open it. Once it's connected, you have this, just snaps on there, that closes the circuit. So the first word in EIT is electrical. So we'll talk about, you need to close the circuit. This here is what's called the reference. So this gets placed anywhere it can reach, but it should be on tissue that is nowhere near your lungs. So usually it's just placed on the abdomen. This is your tissue reference, and then what this does is, this is so small, I don't work in pediatrics, so this is very tiny. This is interesting. Yes, I won't bother connecting it all, but what you have, I'm going to show a picture here to go along with what I'm saying. Okay, so in terms of where the belt is placed, we place it between the 4th and 5th intercostal space. Okay? Originally, when it came out, the manual would say between the 5th and 6th is okay. After years of experience, and even Draeger will say use 4th to 5th intercostal space, so don't go below. What starts to happen is you start to have diaphragm artifact if you have a lot of movement of the diaphragm or spontaneous breathing. So staying between the 4th and 5th intercostal space is ideal. If you have any bandages or something you need to avoid, it's better to go up than it is to go down if you have to move the device. The device will function, this one has 16 leads. If you have a chest tube, for example, it could work if it's missing one lead, but if you have 2 leads missing, it starts to have an issue, and it will usually warn you saying the signal quality is low, and there's ways of checking the signal accuracy. When you put this around the patient's chest, all of these leads should be below the red line. What this means is that it has good contact. Okay, so when you put it around the chest, sometimes 1 or 2 leads might be high above the line, and it shows you on the screen which one is which. So if you place it properly around the patient, one side is lead 1, and one side is, so this is 16, and this is 1. So when you place it around the chest like this, obviously I need more than a medium for myself, but when it goes around, you have 1 and 16, and it shows you right here, 1 through 16. So when there's a problem, it actually highlights it in red. So if it says 6, you go, oh, it's on the left side of the patient, number 6 is down here. And all you need to do, sometimes just wetting your hand with water, and just rub the lead, the water improves the contact. Otherwise, if you have a very patient with a lot of body hair, water is sometimes not the best, but ultrasound gel the gel we use for ultrasound, you can just place a small amount and just place it on there, and it has better contact when there's hair, I find, than just plain water. But usually just wetting the lead does what you need it to do. Now, I said it's electrical. It sends an electrical current. It's not felt by the patient. It's a very small frequency. It sends it around the belt, and then each pair of electrodes, so this is just a picture, I mentioned 1 through 16. Each pair of electrodes, based on the reference lead here, sent to each one of these, and each pair measures the impedance, EIT, impedance. It measures the impedance, which is just the resistance. So the resistance of that current going to each of these leads, each pair is measured the resistance from here. It goes around the chest. Then it moves the reference lead to here. And it does the same thing again, okay? And once it reaches around the chest once, you have a tomographic slice, EIT, electrical impedance tomography. Okay? So you end up with a tomographic slice, but does anybody want to guess how many times it goes around the chest in 1 second? 50 times. The beauty of computers. So it does one full cycle 50 times. So if you were looking at a CT image, right, for example, and let's say that image was measured 50 times in 1 second as the patient breathes, you don't get a picture anymore, you get more like what looks like a video, right? It's like a cartoon, because the image is changing 50 times per second as air is entering the lung. So when I say it's measuring the resistance of the electrical activity, the resistance changes based on the impedance of air. So as air increases in the lungs, it changes the signal, and as air exits the lung, it exits. You'll notice on the screen here, this looks like a tidal volume waveform on a ventilator, right? This is the impedance change in real time. This is a simulated patient, and you can see when an image shows you 50 times per second, it ends up looking like a video. So this is the distribution of air entering the patient's lung in a tomographic slice. So if I point to the sternum, is it here? Or is it here? That's the sternum. It's a tomographic slice, right? So it's what they call caudal cranial view. So I'm looking at the foot of the bed towards the patient. So is this the right side of the patient or the left?
Left side.
Left side, yes. We're looking from the feet towards, again, slice. You slice me in half, please don't. But this is my left side, so that's the patient's left side, and that's their right side, okay? So this is important for understanding, particularly when the images look different. So I've already explained all of this. So we have patient's left side, the patient's right side, anterior, posterior. In terms of normal distribution of ventilation in a normal patient, if I were to wear this and to lie flat, or maybe not myself because I'm spontaneously breathing with no ventilator, but when you place it on a patient on the ventilator, normal distribution is approximately 50% between anterior and posterior. Okay. And this is important later. Now, the height of this waveform that I showed you, I'm going to go back to the waveform screen. And I'm actually going to set quadrants here. There we go. Oh, quadrants are a little off. One second. There we go. Okay. Now, this is the height of the impedance change. What is this tidal volume? No. It represents the volume entering the lungs, but because this is measuring electricity, they're just measured in what are considered arbitrary units, and they call them delta Z. Okay, so this is the change in delta Z. Now, if the belt is placed in the correct position, the change in delta Z divided by tidal volume gives you a ratio that you can use to calculate volume going to different regions if you want to know exactly how much tidal volume is going to an area. However, it gives you percentages here. It's the percent of the total distribution going to whatever regions I select. So I just made it so that this is region 1, 2, 3, and 4, right? So region 1, 32% of my ventilation is occurring up here on the patient's right side anterior. 25% is on the left anterior, 24 the right dorsal, and 18% left dorsal. Okay? Yes.
So usually four,
It depends on how you, yeah, so right now I have set it up in quadrants. Before I did that, it was in layers, which would be anterior, mid-anterior, dorsal, like mid-dorsal, and then dorsal. It
depends.
Customizable, yes. Now, one of my favorite is actually not one of the options here, but you can customize it, but instead of showing, I'll show you on the screen how that works. But each area is a region of interest, right? And I mentioned the quadrants there, so we have 22, 24, 32, 21. It may change slightly. You can connect it to the Draeger ventilator and actually bring in tidal volume. So this is global tidal volume is almost 400 mils. 23% is going in one region, 24, so you see a percentage of where this volume is going. Very interesting stuff. Again, the clinical outcome data, I'll get to the end, we don't really know how to perfectly utilize it at the bedside, but what it's telling us is things we couldn't see this before. And this is what's important, is that it's giving us opportunities now to understand more what's going on. Simple, also like Lorenzo said with esophageal pressure, it provides us much information. We still don't know the best way to use that information to change clinical outcomes if they can be changed. So one of the ways I like setting it up, it's called free, you can customize. So all I've done here is I've taken 1 and 2 and I've overlapped them. So this is 1 and 2, but I've just stretched it across, and this I've stretched it across, and I've just covered up the bottom ones because they don't matter. But this is anterior posterior. Right? So if you like an anterior posterior view, you can do this. This says 36% in the top, in the ventral regions, 64 in the dorsal regions. Now, I'm going to quickly show, this is not real time, it's a screenshot. This is my reference. So if I walk up to the bedside before I make any changes and I hit reference, it's going to take my peak inspiratory from my previous breath and put it down here. Now when I make changes, I can actually hit this, which is called display change. Right now I'm not on a ventilator, I'm not making any changes, so it's showing me nothing. But this is the peak from the previous breath, that's real time, and that's my reference. So this is my reference. Notice how 68% of my ventilation is going to this region, and only 32%, this is my reference number here, 32% to my dorsal lung regions. This is what the lung looks like now, and it's completely switched. Did I could tell you maybe I just increased PEEP and I have a perfect PEEP responder. What else do you think I could have done that may have done this?
يشوف برضه elliptic lung and then maybe helpful should if the treating give during recruitment help in
So if I saw this, the first thing I would attempt would to see their response to PEEP, which I'm going to show you slides where we looked at this patient's response to PEEP. Now, if I told you they did not respond positively to PEEP, what do you think we did that improved ventilation so much to the dorsal lung regions? Prone position, yes. This is the response of prone position. So the color differences you see here, there's blue and there's white. Some people think white is bad. White is okay if it's evenly distributed, right? White is just the maximum point of impedance change. But if it's equally distributed, much more homogeneous, it's still a little brighter here, but the more evenly distributed the white is, it just means that the maximum point of impedance change is more homogeneous. It is definitely not homogeneous at all here. It's all, the maximum point is right here. This is a patient who, if you're giving 6 mils per kilo of tidal volume, you think you're providing safe tidal volume, but the majority of it, almost 70% of the tidal volume is going to just the anterior region of the lungs. Right? So if I can't increase PEEP to improve that, prone positioning is the obvious choice. Now I'll show you 2 different examples, but in terms of the data, the distribution has been validated with CT scans in more than one study, so we do trust that the distribution is representing the distribution. But I want to point out the differences, like can we use it, do we never have to do a CT scan again, or should we never do ultrasound? And this comes down to things that are called spatial resolution and temporal resolution. So spatial resolution refers to the lung area or region represented by the image pixels. The belt, I showed you the belt, it's about 4 centimeters in width. okay? And what it captures in terms of the impedance changes is about 10 centimeters, okay? So it's not very precise, specific area. If it was, we'd have to move the belt. Like a CT scanner, you move the patient through the scanner. So CT scanners have very good spatial resolution. EIT does not. It has very low spatial resolution. So for this reason, it cannot be used for diagnostic purposes of lung disease, tumors. Like you don't know what, you can see maybe that ventilation is not occurring somewhere, but the machine can't tell you precisely if it's consolidation, if it's collapse. It just knows that it cannot ventilate. There's things that you can do with the device that will tell you if it's likely pleural effusion, but we can't diagnose things properly with that. You can easily diagnose if someone has a pneumothorax because you're ventilating perfectly, all of a sudden you only ventilate one side, and you auscultate, you don't hear air entry. So it's not that it's diagnostic, but it's highly intuitive, so you would maybe get ultrasound to confirm. So, doesn't have good spatial resolution. The temporal resolution refers to the frequency of obtaining images. And because EIT provides 50 cycles per second, it has high temporal resolution, and it has higher temporal resolution than CT or MRI for detecting dynamic movement of ventilation. So it's really this bedside tool of dynamic movement where it really shines in its ability to tell us information. We recently published a paper, a group of us met in the Netherlands last year, and we basically wrote up this almost like a manual for data acquisition. So if you are interested in research, I highly recommend our paper. Obviously I'm biased, but it reviews all of the things you need to consider. I'm going to review some of the artifacts that you will see with EIT if you ever use it, but it covers proper belt placements, considerations to minimize artifacts, recommendations regarding data acquisition with and without ventilator data. Because, for example, if I'm on high flow nasal cannula, I have no ventilator data. You can use this on a spontaneously breathing patient. But if you connect it to a ventilator, if you want to do certain measurements, you either need the ventilator data or you have to use a certain mode like pressure control and not change the pressure if you want to get accurate measurements. And I think I'll describe that right here. So EIT devices, when you want to do measurements of response to PEEP, it measures changes in compliance. So what is compliance? Mils per centimeter of water. This doesn't have mils, it has those arbitrary units. So it uses those arbitrary units and changes in those units to reflect what changes in compliance would be, okay? So it measures the regional changes of compliance. EIT uses the tidal impedance variation, those waveforms there, as the volume in the regional compliance equations. The pressure part of the compliance depends on whether it knows the pressure, you've connected to a ventilator. If it knows the pressure on the ventilator, you can use whatever mode you want. Okay? If it doesn't know the pressure on the ventilator, so I'm using perhaps this device with this ventilator, then I will have to control pressure because it assumes pressure is not changing. Any change in the height of impedance, it reflects as a change in compliance, and it assumes the pressure is not changing. So you have to use pressure control if you're not using directly measured ventilator data with EIT. And during your PEEP maneuvers, pressure control would have to stay the same. It's very important if you want accurate measurements of compliance. Regional distribution of tidal volume is still represented correctly regardless of the mode. So the distribution does make sense. It's just calculating compliance or changes in compliance is not accurate if pressure is changing and it doesn't know, if the device doesn't know that it's changing. Some of the things that we can utilize. So again, I can see the height that's changing and increasing and going back down again. If I were to do an anterior-posterior, some of the information you can gather just by looking at the device at the bedside. This is an example of having a high PEEP, they lower PEEP, and then they lower PEEP again. On the highest PEEP level, this height represents the tidal volume. Again, it's tidal impedance variation, but it reflects the volume. This is the height going into the anterior portion. This is the height going into the dorsal lung regions. So interestingly enough, what we've learned through observation with EIT over the years is that when PEEP is too high, you don't ventilate your anterior regions because that's the area that's going to be the most impacted by PEEP. So when the ventilator pushes air into the lungs, it actually forces it into the dorsal lung regions, which sounds good, but you're now sending most of the volume into one region of the lung. look when they lower PEEP, notice how the height changes, and they're more similar. If you took a percentage, this is closer to 50% and 50%. Okay, this is more like my 32-68 example, when the person was prone. Now, down here, they drop the PEEP to a lower level. Now, most of the ventilation is occurring up here and very little down here. So I've gone too far with my PEEP. Now, this is not the usual PEEP titration that I'll show you the tools they have, but just visually, you can see these changes in real time as you're changing the ventilator. This is something we call the dorsal fraction of ventilation. So at the highest PEEP level, most of the ventilation is occurring in the dorsal lung region, so over about 60%. As we lower PEEP, it's around 50, and then we go too low with the PEEP, the amount of ventilation reaching the dorsal lung regions is low. So we published a paper in the Blue Journal, just a case report of 3 patients and some animal data, just demonstrating that on day 1, we saw this. Only 19% of ventilation, I know it's pointing up here, but 19% of ventilation is occurring in the dorsal lung regions. So we decided, when we put the device on, we should do a PEEP titration. We increased PEEP and we settled on this image here, which was about 44% in the lower dorsal regions. I said 50-50 is okay, but ended up being 44, and we were much happier with that. PF ratio increased from 77 to 110. Plateau pressure went up by 4, even though we increased PEEP by 9 up to 16. So we've just reduced driving pressure. Whether that changes outcomes, we don't know yet, but this is obviously a move in the correct direction. If you make a change and your driving pressure increases, you have to question whether or not you're causing more injury. But we were happy with that. Tidal volume is the same, compliance improves. The very next day, this is 24 hours later, we look and the dorsal fraction was 62%. So now majority of ventilation is occurring down here. And I mentioned if we're doing PEEP titration and we start high and do a decremental PEEP, we always see that on high levels of PEEP, most ventilation occurs down here. So we made the assumption that perhaps we should just decrease PEEP. So we decreased PEEP from 16 down to 10. So we're almost where we were the day before. PF ratio drops a little bit, but still much better than the day before. Driving pressure had gone up to 10, which is not high, but now it's 7. And then compliance, again, it improved because it had gotten worse overnight. 24 hours. So this is important because when I talk about some of the studies we have where EIT is used only once and never again, it doesn't tell us the information we want to know about the utility of EIT. So when studies get published, randomized control trials, I believe it's important that they reassess with EIT on a multiple day basis. In the esophageal balloon studies, they would measure esophageal pressure for a minimum of 7 days. This is important. We should use EIT sequentially for a number of days if we want to know if it improves outcomes, because 24 hours, this is a very different patient. This is a patient who was doing poorly. We felt we needed to improve them. This is a patient that we've now reduced settings to almost where it was, but look at the difference. So you know what happened in 24 hours with this patient? Fluid diuresis. About 2.5 liters were removed in 24 hours. And this was the impact it had on distribution of ventilation. So this was, and the other cases, examples, all 3 of them had that, the same condition where they were all fluid diuresed in 24 hours, and the impact was actually quite significant. But I mentioned this, we had a discussion before, that if I told you, so as a respiratory therapist, you come on, and I told you, you come on day shift, I was on night shift, the day before they did this. So a night shift, do you think I did anything? I'm not touching the patient. They optimized the patient. The next day I tell you, they optimized the patient yesterday, PEEP is 16. You look and you see these settings, driving pressure at 10, PF ratio 136. Are you gonna go and start playing and like changing everything and decreasing it? You might decrease PEEP a little bit, or you think you're gonna go down to 10? No. So this is important because we might be weaning PEEP, and maybe some of the trials is just the problem we have is how quickly we wean PEEP. Maybe we wean it way too slow. So again, we have visual, now we can visually see the impact of PEEP. We may be faster at weaning it. Other things you can look at when you're weaning PEEP is the end expiratory trend. So there's a whole page that will show you changes in the end expiratory lung impedance, which translates to end expiratory lung volume. More about that in a moment. But if I decrease PEEP over time, you can see with each PEEP step, there's a very slight reduction in this baseline here, and then we go down here, And you can see each time we drop the PEEP, the slope becomes more drastic, the loss in end expiratory lung impedance. And if you look at these values here, this is just sort of a factor of how much we're losing. Notice that we're losing most of the end expiratory lung impedance in region 3 and 4, which is my dorsal lung regions, which it makes sense. They're going to be the most unstable areas when we're reducing PEEP, right? So they're the most likely to lose it. So that's helpful. But I'm going to talk more about problems with this in a moment. But another thing, we talked about recruitment potential. Later I'll talk about recruitment to inflation ratio. We want to know that if we increase pressure in the lung, this is a nice study by Luciano Gattinoni in 2006, where they took patients on 5 centimeters of water and 45 centimeters of water, and notice how there's not much change here. This is a patient with very low potential for recruitment, meaning if I increase pressure or PEEP, there's no benefit. In this patient, when they compare 5 to 45, notice how there's much more aerated regions. I've highlighted them in yellow. These are areas that opened up. There's still some areas that don't open, but of course, when we open these areas, we are worried about overdistension, right? This is one of those things that EIT can show us visually. I have 2 different patients, 2 different increases in PEEP. So this one was a PEEP of 16 to 25. This one, I believe, was 12 to 16. I'd have to look at my notes again, but bottom line is it's an increase of PEEP. And this shows you compliance win and compliance loss, and in which region. In this patient, there's a 35% improvement in compliance in this region, and 2% loss of compliance. It's so low that visually you can't even see any orange. This is a PEEP responder. This patient, there's a 4% improvement in compliance in this little region right here, and a 24% loss of compliance. Not a PEEP responder. This is the patient I probed that I showed earlier. This was their response. When I said they weren't a PEEP responder, this is how I knew. I just went slowly up on the PEEP. I actually went from their clinical PEEP, which I think was 12 or 14, I increased by 4, and then 4 more. And then I put them back on the clinical settings and stood on my EIT device and called up this screen to see what their response was. So I don't leave them on the high PEEP while I'm thinking about it. I put them back on where they were, and then I assessed this. And when I saw this, I said there's no reason for us to try doing PEEP titration, turn the PEEP up higher and do decremental PEEP. I said we should just prone patients. Why? Because that's where the strongest evidence is, particularly if I don't think I'm going to have much benefit to PEEP, I really should go straight to prone. This patient improved very nicely with PEEP. Now, I will point out most patients, it's a balance. There's a little bit of this and a little bit of that, and you have to decide which is worse. But these were 2 extreme examples where there was almost no overdistension and almost no compliance improvements. Okay, other things we can calculate, again, using end expiratory lung impedance. I won't go through all this, but we can actually calculate the amount of volume that was recruited. So if there was a positive response, I can calculate recruited volume, which means with EIT, I can also calculate an RI ratio. Now, it overestimates RI ratio, at least in a recent paper, which I'll show a slide later. But I have some major issues with using end expiratory lung impedance values for clinical use, and this is why. This is the patient that had no ventilator changes going on, so not one item was changed on the ventilator. And this is the end expiratory lung impedance, and notice how it drops. Now the height isn't changing. This is tidal volume, this is plateau pressure, this is PEEP. There's been no changes at all. No change in driving pressure, tidal volume, or anything. What do you think is happening here? I know it says artifact, but can you guess what is happening here? This is a patient getting a fluid bolus. So they're getting fluid, like getting fluid resuscitated, and it has an impact. Again, it doesn't change the height. So remember when I show you distribution and I said, oh, the patients were diuresed, it doesn't affect any of those measurements. It only affects baseline. So when this patient was given a bolus, the baseline dropped. So if I was trying to calculate something using this baseline, and the nurse walks in and gives a bolus for their blood pressure and then leaves, I have a very difficult time trusting that value. So this was published in the Blue Journal in a letter. I apologize for not having the, oh, I did have the reference down there. I published this image in respiratory care in 2019. This is the opposite effect. Notice how it just doesn't stabilize. It just continues to go up 2 hours. This is 12:01 to 14:01. 2 hours, I was waiting for it to stabilize because I was going to show someone how you can do peak measurements and look at this. What was happening here? The nurse walked in and gave Lasix, furosemide. So the patient was now, the urine output increased and it just never stabilized. So the exact opposite of this happened to me. I was emailing Echo from Drager in Germany, Echo, what's going on? And he's like, are they getting fluid removal? And I looked in the room and I'm thinking dialysis. I'm like, no, they're not. And then I went, oh, wait a second. I asked the nurse, did you give Lasix or anything? And she says, oh yeah, right just before you went in there, I went in and gave a bolus. And I was like, is she outputting urine? Oh yeah, a lot. Okay, there we go. What do you think's happening here? It's very rhythmic. Do you have those beds, those ICU beds that vibrate or, yeah. So if you want to use these measurements at all, you have to make sure fluid boluses or diuresis is not happening at that moment. You have to make sure your bed is not doing this. So it has many limitations. But again, the height is not affected. So any compliance measurements you do, they're not affected by this artifact. Okay, balancing the effects of PEEP. Because it can measure changes in compliance, there's a maneuver that we can do with a decremental PEEP trial where you start at a high level of PEEP, and the highest level of PEEP that you choose to do your maneuver, it considers 0% collapse. Again, we know that's not true. It's just that's the reference point. As you decrease PEEP, it will look at changes in collapse that occur as you lower PEEP, and at the lowest PEEP, it assumes 0 overdistension. Again, it's just the reference point of 0. It doesn't mean that there's no overdistension in the lung, but it compares this PEEP level to this PEEP level to show you at the highest PEEP level, this is the compliance that was lost at high PEEP compared to the lowest PEEP. This is the compliance that was lost at the lowest PEEP compared to the high. So this is collapse and overdistension. Guess where we consider maybe the optimal place to put PEEP would be? The balance, right? PEEP is always a compromise. When you increase PEEP, you may have benefit in the lung, you may also have overdistension. So this is theoretically an optimal PEEP. We still need data to actually prove that this is the best place, but theoretically, it makes sense. It makes sense, many things make sense theoretically. It makes sense that better oxygenation improves outcomes, but we realize that's not always the case. So I already described the decremental PEEP trial. This is the example of that patient who was a very high recruiter that I showed you earlier. After I saw his response to PEEP, we then did a decremental PEEP trial. And his optimal PEEP was between 24 and 22. There's this crossing point. Our respiratory therapists in Canada do not like using odd numbers, so we set the PEEP to 24.
I think everyone.
Is it the same here? No one likes odd numbers, right? Okay. Now, one of the things we're learning with EIT is that we sometimes, so for people that use compliance as a method to set PEEP, look, the optimal compliance, the best compliance really is this point right here, which actually has a very high percent of alveolar collapse compared to higher levels of PEEP. So we're learning now that compliance doesn't necessarily reflect the best place that balances overdistension and collapse. You may in fact have a lot more collapse when your compliance is improving. You still have tidal recruitment, so the compliance is good, the volume is still going in, but you may have atelectasis at the end, or de-recruitment at the end. Not all studies use that crossing point. Some have used setting PEEP where you have less than 10% collapse, so this red line here, they would set their PEEP here rather than here, which is actually the same number in this patient, but sometimes that's actually more of a difference. For those measurements, the patients have to be passive. Having said that, there was a recent study published a few months ago of them trying it in a spontaneously breathing patient. Some interesting results. It could be utilized, but right now it was in a very highly skilled EIT center led by Tomas Amari. So I mean, with a grain of salt, like he's an expert in his field. So I wouldn't suggest everyone try doing that PEEP maneuver with spontaneous breathing patients. It can be used to determine recruitment potential. This was a study that we recently published looking at recruitment potential in COVID-19 patients. And as you can see, with low, medium, and high recruitability, you have a different optimal crossing point. This is in the low recruitability, there's very minimal opportunity to reduce collapse, and that's how we defined recruitability, was the amount of change in, or modifiable collapse. There's very minimal modifiable collapse, there's a lot more, and then there's a lot of modifiable collapse with the application of PEEP in the high recruitable patients. As you can guess, customizing PEEP with EIT, this is comparing low PEEP and high PEEP. It's a small study of 15 patients, but of course, optimizing PEEP, whether it's in the prone or supine position with EIT, you end up somewhere in between the PEEP tables. We know whether we say high PEEP or low PEEP, you're gonna end up somewhere in between when you start individualizing patients. So just end with some other some interesting findings. This is some great work by Bhushan Katira and colleagues, and looking at the effect of prone positioning on the compliance within the lung. So what they did is they looked at non-dependent compliance and then dependent lung, this is lung compliance, so transpulmonary pressure, and then looking at respiratory system compliance. In the supine position, respiratory system compliance is here. This is an animal model, by the way. Respiratory system compliance, the highest point is here. And in the dependent regions, it's actually very similar, but in the non-dependent regions, the optimal compliance is over here somewhere. So there's, obviously, if we're titrating PEEP based on compliance, it might be beneficial for one area, but not another area of the lung. And this could be some of the reasons why we don't have good results when we compare PEEP trials. However, when you prone the patient, look at how much more homogeneous it makes the regions of ventilation or compliance within the lungs. The next step for EIT, I know Draeger is working on it. I don't know any other details other than I've seen publications using their device, but it's also available on another device available in the world that you can assess, because we know the impedance of air. What they do for perfusion is they basically stop ventilation, they give a bolus of hypertonic saline, and the device knows the impedance of the saline, and it maps out where that saline is going within the EIT image. So now you have the ability to monitor ventilation, perfusion, and then you have this VQ matching, where the green area represents the most matched regions. So what they did here is they did PEEP titration, 6, 12, and 18. They chose a PEEP of 12 as the optimal PEEP for this patient in the supine position. And again, another utility of EIT showing us why prone positioning is probably beneficial. In the prone positioning, look at the increase on the same PEEP level, the increase in the VQ matching. You can take a picture and slow down. Finally, I'll talk about airway closure later, what we're learning with airway closure, some interesting findings. This was very recently published, 2025, by, again, a group led by Laurent Bouchard, looking at individual regions of the lung and how the global airway opening pressure we may find can be different throughout the regions of the lung. And what they found is that if you're doing a pressure time curve, which I'll demonstrate later, if there's clearly an inflection point. Here there's no inflection point, here there is, but it's much more progressive. This one's much more abrupt. I've seen both of these in clinical practice. This clinical practice, they essentially it's more likely to represent a certain region, and other regions may have very different opening pressures, which is why it's so gradual, it's not abrupt. Whereas the more abrupt changes, you can see there's more of a matching of where that airway opening pressure, it's more diffuse. The airway opening pressure, or I should say airway closure, is involving more areas of the lung at the same pressure level. So you get a very abrupt change, and then opening occurs in almost all regions, where, as you can see here, the upper regions are opening sooner, and then the lower dorsal regions are opening later, just represented by the colors here. These are upper right, upper left, lower right, and lower left, those colors. What they did find, this is another study that looked at one lung ventilation and EIT for the whole lung, looking at the differences in airway opening pressure. Again, in this one here, you can see a very different airway opening pressure than here. It's like 4 centimeters of water versus 16. The interesting finding they had was that when they chose PEEP based on the crossing point that I showed you, it chose a PEEP that addressed the higher airway opening pressure, which is what you would essentially want, provided there's no overdistension. So if the crossing point is where you balance overdistension and collapse, it actually reflected or managed the higher airway opening pressure. And finally, another area that EIT has been used for is looking at the effect of pendulum. So pendulum is the area, or basically the movement of volume from one area to another based on different compliance regions. And with strong effort, what they're finding with EIT is that we're delivering 6 mils per kilo with the ventilator, but they're pulling volume from the anterior portions to the dorsal lung regions. So although we're getting 6 mils per kilo, regional lung stretch is actually much higher than when patients are passive. So here's an example of passive patients. That's the amount of distribution of ventilation going to the dorsal lung regions. During spontaneous breathing, it's going up in the dorsal lung regions while it's going down in the ventral regions. They're literally drawing more volume than you're delivering from other areas of the lung. So this regional strain, this is just 2 different modes of ventilation. This regional strain is called Pendelift, and this is one of the concerns that we now can visually see in patients with high effort. We can see this potential impact. We're trying to quantify. The question is, if Pendelift exists, at what point should we be concerned or not concerned? This work being done by Andy Adler and colleagues looking at trying to quantify it. So they're now describing this fractional reverse impedance change. And for example, this is taking this overall image here that has a 6.1%, which would represent the amount of impedance change that would be significant. And then when they break it down, you can see regionally, there's 32% Pendelift happening here, 13% happening here, and 0% in one region, but globally it ends up being 6.1%. So as you adjust PEEP, you can then calculate this. Again, this is not ready for prime time. This is just concept thinking. Eventually it'll hopefully be in devices like that so we can quantify it. And finally, my last slide is just talking about the limitations of some of the randomized control trials we have. This is not a randomized trial, it's a retrospective analysis done by this group out of China that sort of influenced these studies. They found lower mortality with EIT compared to methods they used prior, and higher weaning success with EIT. Extremely small numbers in this retrospective analysis. Again, it's retrospective in nature, which is problematic. Then they did, okay, let's look at an outcome of driving pressure or respiratory rate. They found that it improved driving pressure and lowered respiratory rate using EIT. But the strategy was used once, and then PEEP was left for 48 hours. And then after 48 hours, they just decreased in steps of 2 every so often. So they never used EIT again. So I mentioned before, we need to use EIT sequentially if we want to get results. So not results, but we want to get information that tells us EIT is beneficial or not for clinical outcomes. You can't just use it once. And this same thing here, the outcome was mortality, but for anyone that does trials, you know that 117 patients is extremely low. Their power calculation, they expected a decrease in mortality of 25% based on this retrospective analysis. So when you do power calculations, if you put that in there, it says, oh, you don't need a lot of patients then to prove it, if that's what you're expecting. So they expected a decrease in mortality of 25%, which is a relative risk reduction of 63. And just for context, the Proning study that we've mentioned many times today, the ProSeva study, they expected a 15% lower mortality than their patient. They had over 400 patients in their study. The Oscillate trial expected a 20% relative risk reduction. And then again, if you calculate this, it's a 63% risk reduction, which is just insane. They expected 20%, and they enrolled 584 patients after stopping the trial for harm. So clearly we don't have the evidence that EIT using the crossing point saves lives or improves outcomes, but A, studies have poor power calculations, and B, they only used it once and then left it for 24 hours and then just used the PEEP table afterwards. Doesn't answer the question. I don't think we need to conclude. Thank you. This was us performing the recruit study right at the beginning of COVID at St. Luke's Hospital. These guys probably recognize these guys here. We got Dr. Michael Sklar and Dr. Lou Chen there, and that's myself. And Sklar's holding phenylephrine. He was handling the blood pressure. That's what he was in the room for. Thank you. Okay, let's have a break for lunch, okay? And then when we come back, we're going to hear about P0.1 and PEOC, and then asynchrony, and then we'll decide how we manage the last few lectures of the day. So let's meet back here just so that we don't have a question about how long. It's 1:15. Are we okay with 40 minutes? Is that enough for everybody? Okay? If everyone comes back here sooner, we'll start, but I'm not expecting it. So we'll start at 2 o'clock sharp.